Assalamu alaikum. Good afternoon and happy lunch. May I kindly ask the people at the very back to come forward? Please try and come forward. People at the very last rows, please try and come forward. Okay, Assalamu alaikum, welcome everybody. We're coming to a very important session on ischemic heart disease, the most common of all the diseases that we have seen so far. Although on the surface it may appear very simple and straightforward, that could be the case in a lot of cases, but in a lot of times it needs particular attention, particular expertise, particular way of thinking, particular handling, and definitely up to date. Before I introduce our first speaker, I'd like to introduce my co-chairs. I'd like to introduce our guest from Dr. Adil Riyami. Dr. Adil Riyami is a consultant cardiologist at the Qaboos University Hospital in Oman. I'd like to introduce my colleague, and by the way, we studied medicine together, Dr. Salah Arafa, who is a senior consultant cardiologist at the Heart Hospital. I used to be at the Heart Hospital in the happy days. I have moved into Al Ahli Hospital and I'm now the chairman of cardiology and cardiac surgery there. As a point of order, we will allow a couple of questions after every talk, but not many questions. After the second lecture, we will allow also questions from Gaza and Yemen who are communicating with us on direct line, and they can see the presentations, and also at the end. So we'll give them a chance twice during the session. I'd like to introduce our first speaker, Professor Paolo Camici. Professor Paolo Camici is Professor of Cardiology at the Vita Salute University, San Rafael. He's also a senior consultant cardiologist at Department of Medicine at San Rafael Hospital. He is interested in the diagnosis and treatment of ischemic heart disease in the broad sense and cardiomyopathy, but he has particular interest in the non-invasive cardiac imaging and even more particular interest in PET examinations. Please go ahead. Thank you.
Well, thank you, Mr. Chairman. Thank you very much. I would really like to thank the organizer for this kind invitation to visit your beautiful country. Ladies and gentlemen. So the title of my talk is Coronary Microvascular Dysfunction and Microvascular Angina. Okay. So what is it? I think that it's not an easy task to go through this problem. So let's start from the things we know. Angina is the most common symptom of ischemic heart disease, and we calculated that more than 100 million people around the world suffer from angina. in many of these patients, the symptoms are seriously restricting everyday life, quality of life, and often lead these people to retire from work at an active age. For about 200 years, we recognized that angina was linked to a lack of blood supply to the heart, i.e. ischemia. And it is now well established that one of the main causes of ischemia is atherosclerotic disease that affects the epicardial coronary arteries. So these are the arteries that run upon the heart, cardias, so epicardiac means upon the heart, so these are the big arteries that run upon the heart and that we can visualize when we do a coronary angiogram. So here you have, this is taken from Mike Davies' typical case. The great advantage is that for almost 50 years we've now developed the ability to see these arteries during angiography, and we know that the hemodynamic consequence of the cardiac stenosis, of the coronary stenosis, is a drop of pressure beyond the stenosis, downstream the stenosis, so that when you need to increase blood flow, you can't increase blood flow. And in fact, there is a direct relationship between the severity of the stenosis, bottom right, and the coronary flow reserve, which is an index of the ability of the heart to increase blood flow. So all this is pretty well established. And the other advantage is we can image ischemia using non-invasive testing like nuclear medicine. This is a SPECT, and this is... Can you go back, please? Can you back? Okay. Sorry. Okay. So at the bottom you have the rest SPECT. At the top you have the stress test. And you see that during stress there are areas, in this case in the distal part of the left ventricular wall and the apex, where you have evidence of ischemia. Now remember one thing. Ischemia due to coronary artery disease, atherosclerotic disease, is generally regional. So you will always see a regional defect. However, over the years, we have understood that in addition to atherosclerotic disease, there is also another type of disease which may affect the epicardial arteries, which is coronary vasospasm. And coronary vasospasm can be transient, like in Prince-Metal angina, or can also be prolonged, the prolonged spasm, leading to myocardial infarction. In this case, now this is the report of a PET scan to measure myocardial blood flow. So can I have a pointer, please? That would be very helpful. You have three set of results. You see flusso stress, flow rest, and flow reserve. So let's start with the middle. Okay. Let's start with the middle column. This is flow in each of the three coronary territory, the LAD, the circumflex and the right, and this is the average flow in the entire left ventricle. And the beauty of PET is that you're looking at absolute flow in units of milliliter per minute per gram. So you can tell how much flow is going to each gram of the myocardium. Then you give a vasodilator stimulus, adenosine, dipyridamole, and you measure flow again, and this is the maximum flow. So you see that it goes from 0.7 to 2.5, roughly, okay? And the ratio of maximum flow over resting flow is the flow reserve. So in this patient that suffer from chest pain, the flow reserve is absolutely normal. He has a normal angiogram, so there is no evidence of anatomical limitation to blood flow. And you do an angiogram. The angiogram shows non-diseased coronary arteries, but then if you run a special test called acetylcholine that in normal coronary arteries produces vasodilatation, whereas in coronary arteries with endothelial dysfunction does not provide vasodilatation, but may induce vasoconstriction and even spasm. You see, this is low dose, nothing. The patient has no symptom. There is an LBBB. But at the high dose, the patient said, "Doc, I have the same chest pain I usually perceive when I'm at home." And you can see here, I hope you can see, that there is a focal spasm of the left circumflex. Can you see the spasm? No? Unfortunately, the quality is nothing you can do? Okay, much better. Can you see the spasm now here? You give nitrates, and the patient is okay. Vasospastic angina, focal type. You can also have a diffuse response. For focal means a restriction of 90% or more relative to the neighbor artery. But you can also have a response which is not focal, it's diffuse. So the entire artery is getting vasoconstricted. Very well. Okay, now, atherosclerotic vasospasm. Let's go back to atherosclerotic. So if you have a plaque, if you have a stenosis, what else you do? You put a stent. You put a stent, you have resolved the problem. That's not true, because we now know from the big trial from this NHLBI registry, from the COURAGE, the SYNTEX, and the BARI2, that patient receiving a stent 12 months after stent implantation, although the stent is patent, will still have in 1 out of 3 chest pain. And this number goes to 60% if the patient has diabetes. I know you have a lot of diabetes in the geographic area, so it's quite likely that most of your patients after stenting will still develop chest pain after the stenting. So furthermore, we now know that when you do angiography, and this number is increasing both in women and in men, of all the subjects undergoing coronary angiography for diagnosing CAD, a good percentage of these patients, we have no evidence of obstructive coronary artery disease. In other words, there is no obstruction on the epicardial arteries that justify the development of myocardial ischemia. Now, why is that? Because what we should realize is when we do an angiogram here on the left, we are dealing with a technique with a spatial resolution of roughly 0.5 millimeter, 500 microns. Sorry, that's a mistake. So we only see vessels down to a diameter of 0.5 millimeter, like, these septal branches here. But the real anatomy is much different. Look at these post-mortem casts. So these are the epicardial arteries, and you see that there is a network of small vessels that are below the spatial resolution of angiography that make up the so-called microcirculation. Okay, so you have the epicardial arteries here, and below 300-400 micromillimeters, you start to have the microcirculation. Why is the microcirculation is there? What is the function of the microcirculation? I mean, this is very clever. As you know, when the heart does more work, we'll need more ATP. And to synthesize more ATP, you need more oxygen. And because oxygen extraction from arterial blood is nearly maximum, because we are talking about 65-70% extraction, the only way to provide additional oxygen is to increase blood flow. Therefore, what happens is the following. The cardiomyocyte contracts more, the Krebs cycle inside the cell runs more to produce more ATP. But during the production of ATP, you also produce superoxide radical, which is then transformed into hydrogen peroxide, which diffuses out of the cardiomyocytes and goes to the distal arterioles that are responsible for the so-called metabolic vasodilatation. So the system is very clever because the cardiomyocyte is surrounded by these small vessels. They receive the H2O2, they will dilate, and they will increase blood flow. So the microcirculation is crucial for the regulation of myocardial blood flow. So it's not difficult to imagine that if you have disease of the small vessel, you will not be able to increase blood flow properly, and you may then go into problems. Okay, this is taken from the chapter of the latest Braunwald book, which I wrote, and for the first time, Braunwald recognized this clinical problem and asked me to write the chapter. And okay, so here we have the mechanism of myocardial ischemia, those linked to the epicardial coronary artery, atherosclerotic disease, vasospastic disease. But now we have a third alternative mechanism, which is coronary microvascular disease. Now, this arrow, bidirectional arrow, is very important because these three mechanisms can coexist. So you can have a patient that has a stenosis, but also has coexistent microvascular dysfunction. This is why sometimes when you treat the stenosis, you still have ischemia, you still have angina, because you don't treat the microvascular dysfunction. What are the factors that are responsible for this dysfunction of the microcirculation? Basically, there are two types of mechanisms which nicely correlate with the clinical presentation. One mechanism is due to anatomical changes. So this is an arteriole which runs within the ventricular wall, so these are called intramural arterioles, and normally these arterioles have an endothelium, a tunica media, and the adventitia. If you have this microvascular dysfunction due to anatomical remodeling, mainly you have hypertrophy of the vascular smooth muscle in the tunica media. So it's like having a stenosis that run all along the path of the vessel. So these vessels become stiffer, the ratio between lumen and wall is increased, and basically this vessel is incapable to adjust in response to increased oxygen demand. Now the problem is that there is no technique that allows us to image these small vessels. These are too tiny. So the only way to study these vessels is to investigate functional parameters that relate to microvascular function. And the most important parameter is the flow reserve, because going from resting flow to maximum flow, you need the microcirculation to dilate properly. And the best technique to do this is to use positron emission tomography. Positron emission tomography, as I show you, can measure blood flow in absolute units of mils per minute per gram. So you can measure resting flow, maximum flow, and the ratio of maximum flow over resting flow is the flow reserve. Now, how does this translate into clinical? Let's take the first case scenario. So this is a patient that complains predominantly of effort-related angina or effort-related symptoms, which can, for instance, be dyspnea. This is a flow chart that I proposed for the diagnosis of this condition. So you have anginal symptoms. You generally run a stress test. For instance, the patient does a ECG stress that shows ST depression during exercise. And typically in this patient, if you do an echo stress, you will see that although the patient has chest pain and although the patient has ST depression, there is no regional wall motion abnormality. So this is the main difference between this condition and typical CAD. You remember in typical CAD I told you that you have regional ischemia. So you have regional perfusion defect, regional wall motion abnormalities. In this case, there is no evidence of that. So what can I do to diagnose? I have to do a study of flow. So I submit the patient to PET scanning. Now, this is the typical situation of patient with hypertension. Most likely if they also have left ventricular hypertrophy. This is a study that we did in 40 patients with LVH and normal choreoangiograms, and in a controlled group using PET. All the patients had normal choreoangiogram, but you see that compared to the controls, during stress, the increase in blood flow in the patient was almost half compared to the control. So there is a severe limitation to increase flow during stress. And these are the microscopic pictures of the vessels of these patients that compared to a normal heart, I'm sure you can appreciate the increased thickness of the arterioles, which is even more pronounced in patients with primary hypertrophy, such as those with hypertrophic cardiomyopathy, that also have severe microvascular dysfunction. So what you do, you run a PET scan, and you see that compared to the previous PET scan I show you, in this case, flow increases only modestly going from rest to stress. And the flow reserve is around 2 instead of the normal 3 to 5. So there is impairment of flow reserve which is diffuse. And this is the main characteristics of this condition. So the entire left ventricle has a reduction of flow reserve. This is not regional. Now, in this paper I published with Marcello Di Cardi about 3 years ago, we had a group of almost 600 patients, and we demonstrated that both male and female with a severely reduced flow reserve, you see less than 2, have a much worse outcome to compare to patients with a flow reserve greater than 2. So this microvascular dysfunction bears prognostic information. Now, the second case scenario is a patient that complains predominantly of chest pain at rest. So the chest pain is not related to exercise. In this case, the cause is not anatomical, it's a functional disturbance, which can be either impaired vasodilatation or excessive vasoconstriction. So the vessel does not dilate in response to stress, or actually, under certain circumstances, can go into spasm. Now, in this case, if you run a flow reserve, the flow reserve is normal because there is no anatomical limitation. So what you have to do acetylcholine. But the thing is, can you, okay. As you can see here we are at the high dose, 100 micrograms, and the patient says, "Doc, I have chest pain, there is ST depression," but if you look carefully, there is no evidence of focal spasm. So the patient has symptoms, there are ECG changes in the absence of focal spasm. This is what we call microvascular spasm. And if you administer nitrates, the patient feels better. So this is the second case scenario. I mean, there is no time, but it's important to ascertain which one of the two is the cause of ischemia, because then you can use specific treatment for one or the other condition. So this is my take-home message. Transient myocardial ischemia can be due to different causes that act alone or in combination. Each mechanism can be investigated using a combination of invasive acetylcholine test or non-invasive test, flow reserve with PET. Understanding the underlying mechanism is the prerequisite for the choice of the most appropriate therapeutic strategy. Thank you.
We'll take the question. You can take one, maximum 2 questions. Okay, since you are near the mic, and then after you.
I'm Dr. Mishra from Al Ahli. Thank you, sir. You give a very nice presentation. I just wanted to know this acetylcholine-induced vasospastic test which you have been doing with PET patients, how safe it is and how, there are limitations for the test when you do it.
Oh, this is an important question because the stimulus we used to use previously, ergonovin, was not very safe. Now there is a series published by Ong in Circulation in 2009 in over 1,000 patients showing that the incidence of serious side effect with acetylcholine is almost zero. The most common effect is a transient AV block due to the parasympathetic mimetic action of acetylcholine, which disappear easily if you give a bit of atropine. So the test is very safe.
And is it possible to incorporate metabolic in addition to just the coronary blood flow with PET?
Like what? Lactate? What do you mean?
Like FDG, fluorodeoxyglucose, or will it have some?
Yeah, but I mean, because this is a diagnostic test in the clinic, you want to be quick. So what you do is you have the patient on the table, you look at the angiogram is normal. Okay, before you send him off, you do the acetylcholine, and you normally do 4 doses, scalar doses, and it only takes, let's say, 15 minutes. You don't want to make it more complicated. Just keep it simple, do the diagnosis.
Thank you.
It will be change our TMT for a false positive TMT. It means there is no false positive TMT.
Yes, I mean most of these patients were labeled as false positive because the gold standard was coronary angiography. Now we know that coronary angiography is not the gold standard. I think, coronary angiography is the gold standard for atherosclerotic disease. It's not the gold standard for vasospastic disease, neither for microvascular disease. So we have to accept that the mechanism of myocardial ischemia are multiple, and they need different ways of investigation. So you need the acetylcholine, you need the flow reserve. I'm not saying, atherosclerotic disease is clearly there. And if I have a patient with a left main or a proximal AED, of course I will do stenting. But in many other cases where stenting is done inappropriately, because we know that stenting, for instance, does not change the prognosis of the patient. And often if I stent, the patient has recurrent chest pain. So I have to use optimally medical treatment and understand what is the underlying cause of ischemia.
Who's presenting us? Okay, thank you so much. Thank you.
Do you want to present it?
Thank you so much, and thank you for being on time. I would like to introduce the next speaker who's going to talk to us about dual antiplatelet therapy after drug-eluting stent. Dr. Kirk Noel Garrett is from he's the current president of SCAI, and he had his training in UCLA and has a lot of publications under his belt. He's the chief of cardiology and director of cardiovascular research in Washington, Delaware.
Well, thank you very much. Real pleasure to be here. It's been a lovely few days here in Qatar, and I've enjoyed very much my time and appreciate the opportunity to speak today. I'd like to make some comments about dual antiplatelet therapy for patients receiving drug-eluting stents, and I was specifically asked to describe what we've learned in the last 5 years. No surprise, it's been a pretty active time in this area, and the last 5 years have taught us many, many lessons. I think it's fair to say that prior to 5 years ago, this was sort of the consensus opinion about duration of dual antiplatelet therapy after a drug-eluting stent. Everybody had an opinion, no one really had very good data, and then of course in the 2007-2008 period there was great concern about this. Data coming largely out of Europe that suggested that in fact mortality rates late after stents were implanted were trending higher for drug-eluting stents than bare metal stents. This was very alarming and in fact caused the U.S. FDA to call for a definitive large-scale trial that would help us understand just precisely how much risk was there and how long should we tell patients to take dual antiplatelet therapy. This triggered a flurry of studies to be done. In my opinion, the most important, certainly the most remarkable, was the dual antiplatelet therapy study organized jointly by Laura Mowry and Dean Kariakis. I was privileged to be a part of this study. This trial took patients receiving any type of stent, bare metal, drug-eluting. They all received 12 months of open-label dual antiplatelet therapy, after which they were randomized to continue on with a dual antiplatelet therapy regimen, although in blinded fashion, or they received blinded placebo. This is a nicely designed, large-scale, placebo-controlled trial. The only trial, by the way, to be powered to test for stent thrombosis as an endpoint. And what did we learn from the DAPT trial? We learned the following important messages. The first primary efficacy endpoint was stent thrombosis. As mentioned, the trial was powered for this. And we observed in the DAPT study that prolonging dual antiplatelet therapy from 12 months out to 30 months was associated with about a 70% reduction in the relative risk of stent thrombosis, an absolute reduction of 1% of patients treated. The second co-primary endpoint, efficacy endpoint, was the composite of major adverse cardiac and cerebrovascular events, death, MI, or stroke. And once again, prolonging dual antiplatelet therapy was associated with an important reduction, about a 30% relative risk reduction, absolute reduction 1.6%. That was chiefly achieved through about a halving of the rate of myocardial infarction between that interval from 12 months out to 30 months. The primary safety endpoint was a measurement of gusto bleeding, gusto moderate or severe bleeding, and as anticipated, prolonging exposure to dual antiplatelet therapy was linked with an increased risk of bleeding. The proportionate risk was about a 60% relative risk of important bleeding with prolonged therapy, an absolute risk increase of about 1%. There was also this curious signal of increased mortality associated with prolonged dual antiplatelet therapy, and although the debate around this persists to some degree, at least in the context of this trial, it appears that that death signal was largely accounted for by an imbalance in the number of patients entering the trial who were known to have a cancer. And most of those deaths were not bleeding deaths, but they were deaths related to cancer or other causes. Well, this raised then an important question about the balance between bleeding and ischemic events. And specifically, how much bleeding should you be asked to tolerate in order to achieve certain reductions in ischemic event rates? Interestingly, before the DAPT study trial was completed, an important decision analysis paper was published. This study found that if a treatment, say prolonging dual antiplatelet therapy, increased the risk of bleeding by 70%. In terms of quality adjusted life years, that adverse effect would be balanced if the therapy could reduce stent thrombosis by 0.3% absolute reduction, or an absolute reduction in major adverse cardiac and cerebrovascular events of 0.2%. And as I've just shown you in the DAPT study, in fact, what we found was a 60% increase in the relative risk of bleeding, a 1% absolute reduction in stent thrombosis, and a 1.6% reduction in major adverse clinical events. So this would suggest that as measured against an objective instrument of value developed prior to the DAPT trial, that the findings of the DAPT study are compelling with regard to the argument in favor of prolonging dual antiplatelet therapy for patients after drug-eluting stents. But of course, as mentioned, there were many studies undertaken during this interval. It's useful to group them into two groups: those that tested the value of short dual antiplatelet therapy, that is 6 months or less, relative to therapy for 12 months or more, and on the other side, patients who received 12 months of treatment as compared to a much longer course of therapy, 18 months or more. Let's talk first about that first group. This is a composite of those studies done in the past 5 years looking at this question. Now, importantly, you'll see that there are several issues at play that make these studies different than the DAP trial. First of all, they're all much smaller, and none are powered to test stent thrombosis as a specific endpoint. But very importantly, only one of this group was blinded, and there's not much I can say about that other than blinding is important. Also important to know about these trials is that the preponderance of patients treated in these trials received second-generation, more contemporary stent products. And as I'll discuss in a moment, that's an important consideration. None of these trials found any benefit with a longer course of dual antiplatelet therapy. What about that other group of patients who have 12 months versus 18 or more months of dual antiplatelet therapy? Here's that collective of trials that have tested this. Again, the only study in this group to have been blinded was the DAPT trial. And there was greater heterogeneity with regard to the use of second-generation second-generation drug-eluting stents, ranging from less than 20 to more than 60%. And in this collective of trials, only the DAP study found benefit with prolonged DAPT therapy. But again, that trial was focused on the specific issue of stent thrombosis, and none of the other trials were powered to measure that endpoint. All right. Well, I've mentioned the potential importance of second-generation drug-eluting stents in this consideration. This is a composite of data from 5 clinical trials that looks at one such contemporary trial. This happens to be a cobalt chromium-based thin strut chassis stent design with a durable polymer coating that elutes everolimus. And what you see now, if you look at the left side of the panel here, stent thrombosis rates look to be much, much less with these new stents relative to the risk presented by bare metal stents. Similar data are seen with all the other contemporary stent designs that we have. And this has raised an important question now about the applicability of the DAP trial results to contemporary practice. Why would these newer stents be so much less offensive with regard to stent thrombosis in clinical events? Well, there may be several reasons, but probably 2 or 3 factors are most relevant. One is the thickness of the stent design. We can all imagine, you don't need to be a hemorrheologic engineer to imagine that some product that pokes up into the blood vessel with a tall profile and disturbs flow significantly may form more of a nidus for clot formation relative to something that's thinner and more streamlined and allows more laminar flow. And in fact, that is an important distinction between first-generation stents, which look much more like the top panel in this cartoon, relative to today's stents, which look much more like the bottom panel. And then, of course, there's been a lot of discussion about the polymeric coatings used. It is undoubtedly so that the first generation of stents, being brand new products, were imperfect with regard to the types of polymers used, how they were applied, the thickness of the coating, and so forth. And we do know that some of those durable polymers on the first generation stents would peel, crack, and irritate the vessel in a manner that led to chronic inflammation, believed to contribute to neoatherosclerosis and the propensity for late stent thrombosis. So improving those polymers should have made a difference, and we've seen big improvements in these newer generation stents. In fact, we've in many ways moved away from durable polymers toward bioresorbable polymers. Now, I'm not talking about the bioresorbable scaffolds that are in such disfavor right now, a fully resorbable product. I'm not talking about that. I'm talking about an absorbable polymer that's coated on a metallic chassis that can then release drug and vanish, leaving effectively a bare metal stent behind, but now a state-of-the-art, much improved bare metal stent type. This is a panel that shows information collected from 110 randomized clinical trials looking at over 111,000 patients, and just asking the question, how have stent thrombosis rates been related to these different types of stent designs. And as you can see, there seems to be a fairly robust relationship using a Promus Premier chromium cobalt stent, a state-of-the-art contemporary durable polymer-coated drug-eluting stent is the reference point. Almost all the other stents have stent thrombosis rates that are higher. And the higher up you go in this chart, effectively you're looking at older and older products, and as you can see, things have indeed gotten better and better. And then down at the very bottom, there is one stent that is to the right of the reference stent. It happens to be the Synergy stent, an ultra-low profile product with a bioresorbable coating on it, and it has stent thrombosis rates that are even lower yet, which raises then an important question. Well, if we believe that these newer stents are really better, are they less likely to cause blood clot because of the polymer or because of the improvements in the chassis and the thickness of the struts, or can we tell? Well, the jury is still out. We don't know with certainty, but there's one recent provocative analysis that's looked at a number of stent products, some of which have durable products, some of which have resorbable polymer product on them. All of these are contemporary, relatively low-profile stent products. And what you see there in the forest plot on the right-hand side is that the point estimates, they sort of lean a little bit toward favoring the resorbable polymer over the durable polymer, but that difference is not statistically important, suggesting that it's been chiefly the improvement in the design of the metallic chassis that has allowed us to achieve greatest gains in the reduction of stent thrombosis. Well, if we believe that this is true and that our contemporary stents are actually much less likely to clot, that opens the door then to a conversation about potentially even more novel ways of getting at risk reductions and optimal patient care beyond just prolonged dual antiplatelet therapy. Now's the time to ask the question, can we not only shorten antiplatelet therapy, but can we in fact be smarter about the type of therapy that we render? And there are a number of studies underway that you need to know about that will be very important in the months ahead. The first is the Evolve Short DAP study. This is a registry-based study being run by Laura Mowry out of Boston. And in this study, about 2,000 patients will be followed after they receive a contemporary drug-eluting stent, specifically the Synergy product. Patients will receive dual antiplatelet therapy for a period of just 90 days, after which some will, if able, will have the second antiplatelet drug stopped and continue on aspirin alone. Those patients who are felt by the clinician to still have an indication for dual antiplatelet therapy will be continued. And we'll look to see if a difference in death or myocardial infarction can be observed with these two clinically driven treatment strategies. The results of this trial or this study will be available next year. Two studies which are, for my money, much more important and really much more interesting. The first is the Twilight study, which is the first trial of short DAPT followed by monotherapy that is not aspirin. Imagine, this is really going to be important work. Patients who receive a drug-eluting stent and who also have a heightened risk of bleeding. Perhaps they need anticoagulation for atrial fibrillation or some such. So high bleeding risk patients, they'll receive a drug-eluting stent. They'll all get 3 months of therapy with aspirin plus ticagrelor. And then after 90 days, half of them will continue on in blinded fashion with dual antiplatelet therapy. Half of them will have the aspirin dropped and will continue on with ticagrelor alone. I got to say, 5 years ago, this would have been considered really, really daring. But we have collected in the last few years a fairly solid body of evidence that the bleeding is driven largely by aspirin. Even low-dose aspirin can have powerful effects on bleeding rates in the context of dual antiplatelet therapy. The second trial, which I think is the most exciting, because it's a clinical endpoint-driven trial, is the Global Leaders trial. Now, this is going to test a stent that looks something like the Synergy stent, a relatively low-profile product, with a bioresorbable polymeric coating on it. It happens to be a stent product that's not currently available to us in the United States, but may be available to you here. 16,000 all-comer patient population study. And in this study, the patients will be randomized either to a reference treatment strategy on the right. ACS patients will be obliged to take ticagrelor for 12 months. Stable patients will be obliged to take clopidogrel for 12 months. And everyone will receive aspirin. After 12 months' time then, aspirin will be, the second antiplatelet therapy agent will be stopped, and aspirin will be continued for a total of 24 months. But look at this experimental treatment strategy here. This is really daring. Patients will receive, regardless of their indication, even the ACS patients, will receive dual antiplatelet therapy with aspirin and ticagrelor for just 30 days. And then the aspirin will be stopped, and the patients will be continued on ticagrelor. For my money, this is potentially the most practice-changing, most impactful study ongoing currently. We may see very substantial changes in the approach toward aspirin therapy in high bleeding risk patients on the basis of this trial in the twilight. Meanwhile, while we're waiting for these trial results to be available, there are some useful tools that you should know. They're available at no cost to you and can very much help your decision making about individual patients. The first is the DAP Precise bleeding tool. These data were just published in Lancet recently, and this is a tool meant to help you assess the risk of bleeding in an individual patient during the first year of dual antiplatelet therapy. This is just a histogram that shows you distribution of bleeding events based on the bleeding score that was, I won't bother you with how the bleeding score was generated. But I will tell you that this bleeding score can be calculated with knowledge of just 5 clinical variables: the hemoglobin, the white blood count, the patient's age, the creatinine clearance, and information about whether the patient has ever had a bleeding event in the past or not. It's really quite simple. If you have a patient whose hemoglobin is 11, you get 7 points, say. If their white count is 9, you might add up 4. Their age is 70, they get 9 points for that. Creatinine clearance is 50, they get 12 points for that. And even if they've never had a bleed in the past, their bleeding score turns out to be 32. Those characteristics are not that unusual in my patient population, and yet this fellow would turn up to land in a very high bleeding risk category, one in whom I would look then to shorten dual antiplatelet therapy to less than 12 months, if possible. Also available to you is the DAP score. The DAP score was built by the DAP trial organizing group. It looked to test predictors of both bleeding events and ischemic events in the DAP population and develop a predictive tool. This is now available to you at no cost. In fact, you can go to the App Store and download the DAP score app onto your phone at no cost. I use that when I'm having conversations with patients about continuing their dual antiplatelet therapy. In the DAP score, scores can range from -2 up to 10. You get negative points for predictors of bleeding that's powerfully influenced by age. So even just age of 65 or more gets you a point. If you're over 75, you get -2 points. But you'll see that the remainder of the variables at play here are dominantly atherosclerotic risk factors, and these predict the increased risk of ischemic events so strongly that patients who accumulate 2 or more points are felt to be better served with continuation of their dual antiplatelet therapy. So what have we learned in the last 5 years? I think the following is true. We have learned that prolonging dual antiplatelet therapy beyond 12 months will lower ischemic event rates, but it will come at the cost of increased bleeding. We have no reason to doubt that the stents we have today are very much improved over the stents we had from just 5 years ago. And so those older lessons may have limited applicability in our patient population. We do have a couple of risk tools that can help us assess the risk and benefit for individual patients, and we should use them. And ongoing trials will hopefully be helpful in letting us understand with greater clarity just how we should take care of this important patient population. And I will stop there, and I thank you for your attention.
Thank you, Dr. Garrett. If we have our transmission from Gaza or Yemen, are there any questions? No. Okay. So questions from Yemen? Do we have a question from Yemen?
Yes.
It seems there is difficulty in transmitting the voice. So the question is, they thanks this excellent presentation, and they want to ask about if there is any specific duration for dual antiplatelet therapy in a patient with left main stent comparing to the other vessel disease.
With a bare metal stent?
No, left main stent.
Oh, left main stent.
Yeah, comparing to the other vessel disease.
Yeah. Well, as you might imagine, left main stent patients were largely excluded from the trials that I've reviewed. And we don't really have clarity from randomized trial data about it. What I can tell you is that while the risk of a thrombotic event is clearly extreme in those patients, the data on contemporary drug-eluting stent implantation in left mains is exceedingly good. And I would say that in my practice, if someone has an ostial or a mid-body left main stent, I don't have any compunction about stopping dual antiplatelet therapy in them certainly after 30 months as per the DAP trial. But in high-risk bleeding patients, I would be comfortable stopping it earlier. Although we don't have trial data completed on these patients yet, I would consider whether a more potent agent like ticagrelor or prasugrel, even clopidogrel, might be a better single antiplatelet drug choice than low-dose aspirin in those patients.
Thank you.
Okay, go ahead.
Alex Lyon from the Brompton in London. Thank you for your talk. Before we throw aspirin away, there are other benefits that are emerging, such as its anti-cancer effects, and I wonder whether in these trials the incidence of cancer has been collected, not least because of the concern of the thienopyrimidines in long-term use on increasing cancer, whilst aspirin may reduce it.
Yeah, a very good point, because we tend to look at things through our prism, and cardiologists aren't as observant about malignancies, perhaps, as other groups may be. So I think that we will collect that information, not only because aspirin may have some suppressive properties, but because specifically this question has been raised. It was raised importantly in the DAP trial, but as you know, it was raised by Subramani and others earlier about clopidogrel and then about prasugrel having pro-malignancy properties. I frankly have a difficult time understanding the biology and how those products are meant to cause new cancers in such a short interval of time. It's pretty clear it's not ascertainment bias, that it's not just more bleeding that led to the discovery of cancers, but rather the argument is that there is really a relationship between exposure to these products and the development of new malignancies. So I couldn't agree with you more that as we walk through this, we have to be observant about lessons that we can extract. Thank you.
Okay, last two questions.
Thank you for your presentation. Is still there is a role for BMS in high-risk bleeding patient?
Bare metal stents in high-risk bleeding patients?
Yes.
Yeah, I would have said that even 18 months or 24 months ago, most practitioners in the United States would have said unequivocally we use bare metal stents in these patients. Many were still using bare metal stents in the ST elevation myocardial infarction population out of uncertainty about their ability to comply long-term with dual antiplatelet therapy. But those concerns are quickly fading. And they're quickly fading because there has been for quite some time now a fair bit of bench data supporting the claim that a polymeric coating should reduce thrombogenicity. And that's why the strut thickness story got so much attention. that in fact polymeric coating may be your friend when it comes to ability to withdraw dual antiplatelet therapy. And with contemporary stents, I think many operators at least, are much more ready to use drug-eluting stents rather than bare metal stents in all patients.
Okay, last question.
Thank you for the wonderful presentation. Any comment on silestazol?
On
Silestazol, Plital. Silestazol.
Silastazol, oh,
Yeah.
I'm sorry. Well, it looks to be a relatively, modest antiplatelet compound, but does have some effects. It's been used as a substitute for either aspirin or phenylpyridine in allergic patients in American populations, but has never been tested as an appropriate first-line antiplatelet agent to use in these patients, and so I think today it's not being used in that manner that I'm aware of anywhere.
Okay, thank you, Dr.
Thank you.
Our next speaker is Dr. Mariam Al-Kawari, who's a Senior Consultant Radiologist and Chief Radiology at Hamad Medical Corporation. Her main interest is in cardiac imaging, and she is currently Chief of Cardiac Imaging across the HMC. Her talk will be on cardiac CT angiography in the emergency room, regional experience, and identifying clinical atherosclerosis with non-invasive cardiac imaging.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon. First of all, I would like to thank the organizing committee for this invitation. My topic today my presentation today about the cardiac CT in the emergency department and the regional experience to identify subclinical sclerosis in with non-invasive cardiac imaging. This is my objective, so we'll discuss first about the role of cardiac CT angiography in the emergency department and triage patients with intermediate and low and intermediate risk patients. Then we will review several studies, including 3 randomized studies, and to show their result for the cardiac CT angiography technology. And then we will go through our research study as first study held in the Middle East, and we will show their result. So as we know, that chest pain is one of the most common chief-completed emergency department, and acute coronary syndrome represents almost 1/5 of the causes of the chest pain in the emergency department. The initial emergency department approach for this patient is either to confirm or exclude acute coronary syndrome, and the triage process for this patient is very difficult and challenging. Most of the patients need more hospitalizations, more diagnostic evaluation, even if there is no new changes in the ECG or no abnormal elevated biomarkers. Subsequently, many patients may show no evidence coronary artery syndrome, but on the other hand, some patients with the acute coronary syndrome or myocardial infarctions can mystically discharge home with high mortality rate. Of course, conventional angiography remains the gold standard for significant coronary stenosis disease, but the diagnostic for low to intermediate risk patients, this is very challenging in the emergency department. And the initial emergency process, including clinical information, clinical history, ECG, and biomarkers, this all can help early risk stratifications, but does not identify which patient can be discharged home safely. On the other hand, the coronary CTA show are approved to have very high sensitivity and high negative protective value to detect coronary artery disease. As I mentioned, one of the greatest strengths of cardiac CT in the emergency is ability to triage the patient in low and intermediate risk patients, and many studies show that this is the CT angiography have sensitivity up to 100% and negative protective value 93 to 100%. Also, cardiac CT angiography can reduce the time between the presentation and diagnosis, can facilitate the discharge from emergency department, and of course, lower the cost in comparison to the usual or classic emergency department protocol. A study performed by Corey and his team, they report that median total time to diagnosis decreased to 53%, and median total length of the stay decreased to 51% after implementation of cardiac CT angiography in the emergency triage protocol. why we perform imaging in the emergency department? Of course, the differential diagnosis of non-cardiac chest pain can be broad and can include very life-threatening conditions like pulmonary embolism, aortic dissections, and extra. Also, cardiac CT angiography is it's considered the best non-invasive method that can be demonstrate all these different differential diagnoses in one scan session. The extracardiac findings easily can be identified in most cases. This is an example of extracardiac finding that can be seen in the routine coronary CT angiography. First patient here show the antima flap for dissection type A. This patient show right pleural fusion, and the last patient show mediastinal fat stranding and lymphadenopathy. The most common extracardiac finding can seen in the coronary CT angiography, of course, pulmonary nodule or soft tissue nodule. The CT technology has rapidly evolved since early 2000 to its current standing as the most sensitive non-invasive test to detect coronary artery disease. Accuracy of the coronary CT angiography for assessing the presence and severity of coronary atherosclerotic compared to the other procedure like invasive coronary angiography reported in many published studies examined more than 2,000 patients. So the quality of cardiac CT angiography is directly related to the evolution of the CT scanner. Increase the rotation velocity of the X-ray tube, increase the temporal resolution, increase the number of detectors to 64 or more, decrease the thickness of the acquired slice to sub-millimeter. All this allows significant increase in the diagnosis accuracy of coronary artery disease by CT angiography, and of course, better assessment for the coronary lumen and wall. So, as I mentioned, many studies, there is more than 50 studies published comparing the diagnostic performance for coronary CT angiography with reference standard, the invasive coronary angiography. This study showed the cardiac CT angiography have sensitivity from 86 to 100% and specificity 74 to 96%. However, as method of validation, 3 publications of multi-center study designed to assess and detail the diagnostic performance of CT angiography, as it's seen here in this table. The first study is the accuracy study. In this study, they examined patients without a known coronary artery disease with stable angina or alteration in the functional test, and they measure the diagnostic performance of coronary CT angiography to detect stenosis more or equal to 70%. And then in comparison to the invasive coronary angiography. And it showed that the cardiac CT angiography have specific sensitivity 94%, specificity 83%, and negative protective volume 99%. The second study is CORE 64. They evaluate the coronary artery by using the 64 multi-detector CT. And then their study include 291 patients with or without known of coronary artery disease with a Gaston calcium score less than 600. And this was the first study quantify the coronary stenosis by coronary CT angiography. And they found that the sensitivity of CTA around 85%, specificity 90%, positive protective volume 91%, and negative protective volume 83%. The third study is by Mejobaum and his friends. They evaluate 104 patients presenting with acute coronary syndrome without ST elevation, classified as high and low risk according to the clinical ECG changes and myocardial necrosis marker. And again, they use the coronary CT angiography as a reference standard, the invasive method as a reference standard, and they measure the diagnostic performance of coronary CT in detecting significant stenosis more than or equal to 50%. And in their study, they showed that the sensitivity 100%, specificity 75%, and negative protective volume 100%. So again, 3 randomized multi-center trial then designed to confirm the previous result with better level of evidence. And this is the study, is the CT-STAT, ACRIM-PA, and RUMICA-2. In CT-STAT, the study involved 16 centers with total number of 699 patients. 361 of the patients underwent the coronary CT angiography, and 338 underwent the MPI, myocardial perfusion scan. And in their result, their study, they showed the result showed that the coronary CT angiography, the patient who went to the coronary CT angiography had a reduction of 54% in time to diagnosis compared to the standard protocol MBI group. The cost also were lower in the patient who were using the CT angiography by 38%, and no changes in the rate of the major cardiac event during the 6-month follow-up. ACRIN-BA study, they involved 1,370 patients at low and intermediate risk in 5 cities across the United States. And this study showed that the patients who underwent cardiac CTA, 83% did not have any coronary artery disease, which allowed them to discharge home with no issue. And of course, resulting significant reduction in the hospital stay length. And from the primary safety endpoint, after 30 days follow-up, the patient have negative coronary CTA, show no event. A ROMI-CAT2 trial, they examined around 1,000 patients. 501 were randomized to the CT angiography and 499 randomized to the standard treatment emergency protocol. And in their study, they showed that the patient underwent cardiac CTA have significant reduction by 7.6 hours in the length of the hospital stay. 50% of the patient coronary CT angiography discharged within 8.6 hours in comparison to only 10% in the standard protocol group. And the time to reach diagnosis was significantly lower in the CTA group than the standard protocol group. And during 28 follow hours, there was only 2 events in the coronary CTA group and around 6 events have seen in the standard protocol group. So what else can CTA provide in the emergency department? Of course, we can perform the triple roll-out protocol, and we can do further black assessment by the CT angiography study. Triple roll-out protocol can provide excellent contrast specifications for the 3 vascular beds in questions: the pulmonary artery, the aorta, and of course the coronary arteries. So the acquisition of a 3-dimensional from the entire thoracic within field of view result the possibility of rolling out the 3 most potential fatal causes is very possible. And the CT angiography with triple out protocol in the emergency department in such a clinical scenario is very useful in clinical scenario when more than 1 fatal causes of chest pain is mostly likely. A black assessment, of course, coronary CTA can do black assessment, so we can identify high-risk black in both obstructive and non-obstructive lesion. We can differentiate calcified and non-calcified blacks. We can detect low attenuation blacks or positive remodeling blacks and spotty calcifications. Bochner and with his team, they demonstrate that the black morphology can significantly correlate with the acute coronary syndrome. So in their study, the author analyzed the black morphology from the patient underwent coronary CTA in ROMI-CAT2 trial, and the author concluded that the patients with the high-risk black had 9-fold increased the risk of coronary artery syndrome. So therefore, they conclude that these patients or the patient with high risk black should not discharge home even if it is representing mild stenotic lesion. This is an example for different blacks we can demonstrate the coronary CTA. So this is cases of stable calcification seen in the left main artery. The second case, I don't know if it's clear. It's seen as, this is an example for unstable black. It is seen as low density core surrounded with thin cap fibroatheroma. And this is the third one is soft black with calcification seen in the proximal LAD. And this is kind of representing unstable black if the total volume exceeds 6 cubic millimeter. Of course, radiation dose to the patients remain the main concern in the emergency department. They found that the mean effective dose of cardiac CTA in ROMI-CAT2 was 11.3 millisievert. Subgroup analysis from this trial report the average dose 6.2 millisievert, in patients who underwent CTA with dual source 128 slice CT scanner versus 12.3 millisievert patient who underwent less advanced machine. Bon and his team, they found that when they're using the prospective ECG gating scan, the mean effective radiation dose was 3.6 millisievert. In other study, the retrospective ECG gating was 13 millisievert, and it is a drop to 5.5 millisievert when they're using the prospective ECG scanning in the emergency department. So as it's clear, the high variability in radiation dose here is mainly due to the protocol and machine. Of course, there is several measures we can apply during the scan, as patient preparation to lower the heart rate, using ECG modulation, lower the tube voltage, prospective ECG gating, and the use of the new technology such as high pitch or 320 slice, which is the single heartbeat acquisition. All these measures can help to reduce the patient radiation. Now let's go to our experience in Hamad Medical Corporation. We had published this study last year in collaboration with our colleagues in Weill Cornell in New York. And of course, Middle East, the atherosclerotic cardiovascular disease in the Middle East became a leading cause of premature death. And this is mainly due to the adverse behavior risk factor, as increased rate of tobacco use, unhealthy diet, physical inactivity, obesity, and others. And we found that there is very limited data regarding the subclinical atherosclerosis in the Middle East country. So we designed this study, and our aim was to describe the CT angiography findings in Qatari populations and in South Asian migrants in Qatar in the middle age group with high risk of coronary heart disease. And we use here the South Asian because this is the most common population, migrant population in Qatar. So we performed our coronary CT angiography in 251 volunteers, as I mentioned, all above 40 years, and with the high risk of cardiovascular disease. And we compare the coronary artery severity, extent, plaque morphology, adverse plaque characteristic, quantitative measures of atherosclerosis in both subgroups. The atherosclerotic severity in our study assessed using the standard 16-segment anatomical analysis, and all segments were coded for the presence of a plaque and severity of the diameter stenosis. The luminal stenosis in our study scored as normal 0%, 1 to 40-90% non-obstructive, 50 to 69% for moderate obstructive lesion, and if it is more than 70% a severely obstructive lesion. Also in our study, we used the segment involved score, and was calculated as the total number of coronary artery segments exhibit plaque, irrespective to the degree of the stenosis. So we give the minimum of 0 and maximum 16. We use also the segment stenosis score, which used to measure the overall coronary artery plaque extent with each individual coronary artery segments, and graded from 0 to 3. And of course, the visualized plaque classified as non-calcified, partial calcified, or calcified plaque using the standard definition. As a part of study, blood sample was taken 1 month before the cardiac CT angiography to measure the blood markers that associated with cardiovascular risk. And in order to have more accurate comparison in CTA findings, our study, we used the propensity score matching, and this score matching including the age, gender, traditional cardiovascular factors. So this is our result in unmatched population. If you compare the South Asian with Qatari, we found that the Qatari in this group were older, more female patients, and with high body mass index. Also, we noticed that the Qatari population in this group have high greater prevalence of diabetes, hypertension, and family history for coronary artery disease. The cholesterol and non-HDL cholesterol was higher in the South Asian subgroup. The blood biomarkers were higher in Qatari population. This table shows more about the black characteristics. So the presence of the black was noted in 40% of overall unmatched cohort. Obstructive disease seen in 38% of the overall unmatched population. Non-obstructive disease was uncommon, and the frequency of pneumoconic disease was common in South Asian population, while the obstructive disease were more common in Qatari population. In the matched population, we found that there is no significant difference in the clinical risk factor. The body mass index and the biomarkers again higher in Qatari population. Total cholesterol and non-HDL cholesterol remain high also in the South Asian as the unmatched population. And we found also that the overall extent and severity of coronary disease is slightly higher in the matched population than in matched group. Obstructive coronary disease observed in 45% of subjects and did not show any significant difference between the two subgroups. Also, there is no significant difference between the South Asian group and Qatar group in the number of the diseased vessels or the extent of the coronary disease, and no significant difference in the black score or black composition between the two subgroups. In the quantitative black analysis, we found that the Qatari were observed to have significantly greater mean vessels volume and a lumen volume than the South Asian. All histological subtype of black were higher in Qataris, but there is no significant or no difference were statistically significant, and the percent of aggregate black volume at per subjects was also no significance between the two populations. So from our study, as I mentioned, this was the first study described the CT angiography findings in the Middle East, and we observed that there is high prevalence of subclinical obstructive coronary atherosclerotic in middle-aged asymptomatic populations. No significant in the CTA findings between the two groups after adjustment of the clinical risk factor. And from our study, we conclude that the identifications of subclinical coronary disease with non-invasive cardiac CT angiography have prognostic significant volume more than the classic emergency department protocol. So my conclusion here, the early triage by coronary CT angiography is viable and reliable and potentially more accurate alternative to functional testing in low and intermediate risk patients who are coming with acute chest pain. And to have this triage with high level of confidence, you should have high-end equipment, CT equipment, sufficient expertise in data acquisition and imaging interpretation, and of course appropriate patient selection. Thank you so much for your
Dr. Mariam Kawari, two questions only, please, because we are running out of time. If there is any questions. Yes, please. Can you go to the microphone, please? Listen back.
Thank you. You mentioned prospective ECG gated. Do you use retrospective forms during the evaluation of a patient at the emergency department? If you need some kind of reconstruction to your images, or if there's an artifact, you don't use it?
No, we use it.
No, because you mentioned mainly prospective.
Yeah, no, we use a retrospective.
I'm sorry, the retrospective gated reconstruction.
Yes.
When you mentioned mainly prospective image reconstruction.
No, this is actually the different trial. It's not our protocol in our emergency. So we are using prospective ECG, and of course we have ability to have any reconstructions. So this is not our protocol in our hospital. This is different trial and their result.
Nice presentation. Any left main obstructive disease you found in this group? And number two, what do you do with the obstructive asymptomatic patients?
Yeah, in our study we found significant obstructive lesion in asymptomatic populations, and of course we refer this one for the second phase, which is the treatment and follow-up. And some patients already went for invasive angiography study and procedures.
Okay, thank you so much, Dr. Mariam. I think we come back to Dr. Kamishi. Dr. Kamishi will have the final talk. It's about the identification of high-risk patients after ST elevation myocardial infarction.
Okay, I promise to be on time, Mr. Chairman. Thank you. Okay, let's start from the facts. There is no doubt that in the past 100 years, the acute mortality and one-year mortality for myocardial infarction has decreased. I mean, the most significant changes coincided with the introduction of the coronary care unit, mainly for the use of defibrillators. Then there was an important change in the mid-70s, thanks to, I would like to remind you that the first big trial, this was an Italian trial, it's called the GISSI trial, that demonstrated the usefulness of thrombolysis, then antiplatelet agents, primary PCI, and DAPT. So it's a nice trend. However, if you look at the present situation, the mortality in 1 year remains unacceptably high, around 20-25%. The major cardiovascular event, and mortality in 1 year at 10-15%, which is quite high. But let's go through the problem, starting with a real case. So this is a patient, 65 years old, presenting with typical chest pain that started about 1.5 hours before admission, and the only risk factors was smoking. Clearly, I mean, the patient is presenting with an acute ST elevation in 2-3 VF with reciprocal changes in the anterior lead, which suggests an inferior STEMI. At angiography, can you please improve this? Okay. At angiography, you can see the stump of the right, so there is a proximal occlusion of the right coronary artery, which suggests thrombosis. And maybe now you can go back slightly. Okay, thank you. Now, if we take this cartoon from the very nice review by Crea and Libby published in Circulation a few weeks ago, we can now recognize the major phenotypes responsible for STEMI. So there are two types of atherosclerotic complication, plaque fissure, or if you like, plaque rupture, and plaque erosion. Now, what has become apparent is that there are two types of plaque fissure, one that is associated with evidence of inflammation, so these are the patients that will have high C-reactive protein, for instance, and there is also a plaque fissure that is not associated with evidence of systemic inflammation. In addition, there is plaque erosion. Plaque erosion is different from plaque fissure because the plaque does not have the thin cap like in plaque fissure. There is no clear lesion, but it's characterized by a diseased endothelium. So the endothelium has lost some of the ability to avoid platelet aggregation, for instance, and in fact plaque erosion is characterized by a white thrombus because of a thrombus created by a platelet adhesion. So these are the three main phenotypes. In addition, the authors recognize that there is a third feature that is observed in patients who developed a clear acute myocardial infarction without evidence of any atherosclerotic lesion. And this can be due to, for instance, epicardial or microvascular spasm. In fact, if you look at the literature, there are several examples of patients, in this case is a multivessel spasm, you can see here, developing acute myocardial infarction, or even cases associated with the development of cardiogenic shock due to chronic prolonged spasm. Now, let's go back to our patient. So, the patient is taken quickly to the cath lab. The right coronary artery is reopened. A stent is positioned at the site of the occlusion, and so the vessel is now patent. But those of you who have experience can tell that there is something wrong in these vessels. And the main problem is that the washout of the contrast is very slow. So there is a slow washout. So Dr. Colombo, who was in the cath lab, can you? Okay. Administered nitroprusside and adenosine in the attempt to improve the washout, but it doesn't seem to produce much effect. So it's a condition of a patient with the thrombotic occlusion of the right coronary artery that has been successfully recanalized and treated with a drug-eluting stent, but despite this recanalization shows a very slow flow. And we know that this is due to something that goes wrong in the microcirculation. There are several hypotheses. This is due to the debris of the thrombus that has occluded the small vessel, although the trials using protection devices have failed to demonstrate any favorable effect, like also thrombus aspiration, or it could be due to microvascular vasospasm. But this is known as the no reflow phenomenon, which is the inability of a previously ischemic region to be reperfused despite achieved patency of the epicardial culprit vessels. And this is due to a number of factors, including individual susceptibility, distal embolization, reperfusion injury, ischemic injury. And I think one of the important features of this is tissue edema that develops during the acute infarct that can compress the microcirculation. So how do you define no reflow? Well, as I said before, the first diagnosis can be made in the cath lab, either simply looking at the washout, so in a non-quantifiable way, or using the TIMI frame count, and anything below 3 is considered as slow flow, or even better, looking at the blush grade, which is the disappearance of the tissue phase of the contrast. But more recently, it has become apparent that magnetic resonance is also extremely important for the diagnosis of no reflow. And here you should look at two different things. One is the T2 stir sequence that you see on the left, and that shows edema in white, and you see that actually all the inferior wall and the inferolateral wall is edematous, but also the first pass. And you see that here on the first pass there is evidence of an area of hyperperfusion, particularly in the subendocardium. So this is the first passage of gadolinium across the myocardium, which represent mainly perfusion, that shows that there is an area of no flow in the inferior wall. But the most important thing is to wait 10-15 minutes after gadolinium injection to look at the complete situation. So here you have two types of lesion. You have the white lesion of late gadolinium, which is equivalent to the area at risk and to the necrotic myocardium, and within the late gadolinium lesion you have this black area in the subendocardium that is what we call MVO, microvascular obstruction. So, and this is an area that was never reached by the contrast. So this is why it's black, because the gadolinium never got there because of plugging, obstruction of the small vessels. Now we have published a paper a few months ago in Circulation Imaging in 90 patients, and what we found that in addition to providing information to the existence of microvascular obstruction, the presence of microvascular dysfunction bears important prognostic information. Here, the patient was stratified according to the absence in green or presence of microvascular obstruction, and you can see that MACE-free survival was much worse in those patients with microvascular obstruction. On the other hand, if you stratify patient on the basis of the angiographic parameters, either the TIMI flow or the brush grade, you do not see any significant difference, which means that MRI is more sensitive in discovering the lesion. The problem is that MRI is done after the patient has gone to the cath lab, so it would be important to develop some new index in the cath lab, because if this problem is discovered in the cath lab, you may think to develop some new strategy to avoid the problem of MBO, but there is none at the moment. Now, the other thing that is novel and derived from this study is that not only the prognosis was worse, but those patients on the left who had evidence of MVO had also a larger number of target lesion revascularization. What does it mean? It means that most likely the disease that is responsible for the infarction and for the no reflow is interesting not only the microcirculation, but the entire path of the vessel going from the epicardial artery to the microcirculation. So these patients are more likely, are more prone to develop new occlusion at the level of the stent, or even totally new lesions. And again, this is not appreciable if you stratify the patient on the basis of the angiographic details. Now, looking at the parameters that could predict the incidence of MVO, what we found is that the most important parameter was the ischemia time. So no reflow is more likely to occur in patients that arrive late to primary PCI. So ischemia time is the number one factor. The other interesting factor is that there is a correlation between the presence of MVO and troponin peak. It's not only troponin peak, but also the troponin measures, the first troponin measured at the time of admission to emergency department. So you may say, okay, this means that the presence of MVO depends on the infarct area, on the extent of the infarct. That's not true, because statistically speaking, MVO is an independent predictor of prognosis independently of the troponin. So it's a bit intriguing, but this is well. The other factors, of course, are this one, the left ventricular systolic volume, and the presence of edema. So edema is very important, because the presence of edema in the infarcted area means a lot of extravascular water that actually will compress the small vessel, contributing to occlude them. These are the follow-up data. And again, the patients are stratified based on MR on the left or angiographic no reflow. And you have those with MVO present, red, and those with MVO not present in black. And these are the difference between the first MR and the MR done after an average follow-up of 196 days, so about 6 months. What is interesting is that those with MVO, after 6 months, have evidence of dilatation, not only dilatation, but also evidence of remodeling, as demonstrated by an increase in the diastolic volume, as well as a significant reduction of the ejection fraction. So these patients with MVO are those patients that more rapidly progress towards development of ventricular remodeling and eventually congestive heart failure. Whereas if you stratify patients on the angiographic parameters, there is no evidence that they can identify and predict which patient will undergo remodeling and development of heart failure. So what is the message? The message is that CMR showed a higher diagnostic accuracy for no reflow. MVO, microvascular obstruction, identified a group of patients at higher risk of MACE at follow-up. Clinically driven target lesion revascularization during follow-up occurred only in patients with MVO. Troponin at admission with a cutoff 1.6 microgram per liter was a significant predictor of MVO. Troponin peak of 3.0 was a significant predictor of both MVO and MACE at follow-up. Thank you.
Thank you so much, Dr. Kamishri. We could allow 2 questions, very quick ones, and then we give the priority to our colleagues from Gaza and Yemen. Do you have them? If it's ready, go ahead.
Thank you so much, Prof. Actually, this is one question of one of my colleagues from Palestine. They are watching us live stream. Dr. Iyad Abu Shaira, consultant cardiologist. He wants a comment from your own experience about whether there is a specific approach to manage microvascular disease. Maybe it's related to your previous lecture. I mean, apart from maximizing the anti-angina and risk factor control, anything specific from your experience you can advise us? Thank you so much.
Thank you. Good question. I mean, this does not apply to the acute situation. I can comment on the patient with chronic disease. I think it's important to identify which of the 2 mechanisms I discussed is responsible for microvascular dysfunction. Now, if it's effort-related ischemia with a reduction in flow reserve, as I show you, this is due to remodeling of the arterioles, increased thickness. And this is most likely to be associated with in patient with hypertension, so the typical patient with hypertension. So you have a number of drugs you can use to reduce blood pressure, but not all will have the same effect on the microvasculature. So the best drug is to use the last generation ACE inhibitor like perindopril or ramipril. There is evidence that they can reverse the remodeling of the arteriole. This should be associated with high dose statin to stabilize the endothelium. On the horizons, there are also new drugs like the soluble guanylate cyclase stimulator. These are Viosiguat, Periciguat. These are drugs that have been tested in the Socrates trial for treating primary pulmonary hypertension. Now, primary pulmonary hypertension is characterized by changes of the pulmonary arterioles very similar to those in the current circulation. And actually, I'm now applying for a grant to do this type of treatment in my patient. If the symptoms are mainly occurring at rest, and this is the majority of patients, and you have a positive acetylcholine test demonstrating either epicardial or microvascular spasm, well, the first choice drug are calcium blockers. I normally start with diltiazem because it's generally better tolerated, less side effects, but you have to go very high with the doses, like 180, 240 milligrams twice a day, or you can use verapamil, again very high doses. Sometimes I've gone up to 600 milligrams of both. You don't have to be, you have to be patient. Go gradually until they respond. Again, it's crucial to give the highest tolerable dose of statin. In Japan, they use ROCK kinase inhibitor. One of them is called Fasudil, and they have a nice experience, and the patients seem to respond well. Unfortunately, we don't have these drugs yet in Europe, but some of the drug companies are developing new ROCK kinase compounds. So it's crucial to understand which is the cause.
Thank you, Dr. Fahmy, and then Dr. Adel.
Thank you very much for this wonderful presentation. Actually, this is a question from our colleagues in Yemen, who are also as well. They are sharing with us this conference. And the question actually is related to the previous presentation, which has been presented before this presentation. And the question is, does exercise improve the microvascular disease or not?
I'm sorry, I'm not sure.
Does exercise improve microvascular disease?
I'm sorry, I have no data. I can't. I don't see how exercise could improve. Actually, my hypothesis is that exercise may, if you look at athletes with physiologic LVH, I've studied some of them. I studied the Olympic team, the rowing Olympic team, and those with more than 10 years very heavy exercise burden, they start to have a decrease in flow reserve. So I mean, if we're talking heavy exercise, I would be very careful. Light exercise, I don't think would have any effect on microvascular function. That's my bias.
Dr. Adel here.
Dr. Kamichi, in the no reflow phenomena, one of the things that is cheap and that we tend to see is after you do the intervention and you have TIMI-3 flow, but your STs don't come down. Did you look at the ST segment resolution in identifying a no reflow or microvascular
So
obstruction?
if I understand, is those patients that come with a STEMI, you treat them and they still have ST elevation? Yes, I would suggest that this is a sign, indirect sign of no reflow, because meanwhile you have reopened the thrombus and you have put the stent. So the idea is that reopening the artery is crucial. There is no doubt that, if there is a situation where PCI has changed things, is acute infarction, whereas there is no evidence except for maybe the main stem that PCI changes the prognosis in patients with chronic disease. But in this case, it's clear that PCI changes the prognosis in patients with infarction. The thing is that you have only tackled one of the factors responsible for infarction, because we don't know whether microvascular obstruction is the consequence of reflow, as many things, so it's a sort of reperfusion injury, or whether maybe was coincidence with the development of infarction. So we don't know. In any case, removing the thrombus and putting the stent is just resolve one of the problems responsible for myocardial ischemia and necrosis.
Thank you so much. Thanks to our speakers, Dr. Kamichi, Dr. Garrett, and Dr. Mariam. And thanks indeed to our audience. And we hand over to our colleagues for the last and final session on heart failure. Thank you.